Well, hello everybody. Welcome to another exciting session in World Thrombosis Day week. And this is from Thrombosis UK. We've got this series of webinars, and this is such a great one. I'm really thrilled to be here and chairing it. So we're going to have an update in the use of direct oral anticoagulants and also mechanical thromboprophylaxis. And it's a real thrill. I've got two of the world experts in each area. They're very relaxed. We've got lots of time, so we've got time for your questions. If you do have any questions, would you pop them into the written section, question and answer, and we'll go through them at the end. So I think that we need to get started. So I'm going to introduce the first speaker, who is very well known internationally, Dr. Cohen, and he's going to give us an update on the use of DOACs in obese patients. And I'm very proud to say, one of my colleagues at Guy's and St. Thomas's. He's a world-renowned epidemiologist of venous thromboembolism, and he produces numerous papers. So in addition to all his clinical, supervising and teaching work, he actually designs, manages and analyzes clinical trials. And he is chairman and a member of many international trial steering committees, epidemiological and pharmacoeconomics. So he's perfectly placed to talk about his subject. And we're delighted to hear from you.
Well, thank you very much, Beverley and Joe, and it's an absolute pleasure to talk on this subject, which I've worked on with many colleagues, including Beverley. And the topic I was given was update on DOACs in obese patients, but I'm going to broaden this a bit to high body weight. And this is where Beverley and I spend a fair bit of our time at St. Thomas's, but also down the river at Guy's as well on London Bridge. These are my disclosures for research support, consultancy and honoraria, Speakers Bureau and scientific advisory boards, and I'd ask you to keep that in mind as I'm talking. So I would like to start with my conclusions, and then I'll let you relax and I'll wake you up at the end and give you my conclusions again. So DOACs for treating VTE in patients with obesity, the answer is yes. But more importantly, DOACs for treating patients with obesity and high body weight, the answer is yes too. So I have a start with a message for the guideline writers, and I think it's important that we distinguish between a guideline and an opinion. And I think that opinions that don't consider important data, and I'll define what I mean by important data, are just opinions, and that guidance should rely on a balanced view of the data. So my talk today, I'll just go through the background, and then I'll look at the science, as they say, which is a lot of lab data, which I think has the potential to fuel speculation. I'll look at the clinical data, which really counts. I'll look at some of the speculation and the subsequent data, and then I'll conclude. So why are we having this conversation? Well, what the guidance that started this interest came out in 2016, and it was a paper that was entitled The Use of Direct Oral Anticoagulants in Obese Patients, and I'll point out that it said obese patients. And on the basis, the ISTH recommended that the use of DOACs in patients over a BMI of 40 or a body weight of 120 kilos were not really recommended unless you jump through some hurdles. It's a recommendation that's gone far and wide and has been adopted widely, and I'll come back to that too. So what's the epidemiology? Well, we know obesity is a global epidemic and it affects cardiovascular risk. It's a risk factor for AF. It's a risk factor for VTE. About 30% are obese, and actually around 10 to 15%, depending on the population, fit into the ISTH definition of a BMI over 40 or a body mass over 120. And we also know that obesity is a risk factor for recurrences. And there's a couple of major pathways to obesity-induced thrombosis, which I'll go through. But we also have to remember there's some evidence that high body weight may increase intracerebral hemorrhage risk and perioperative bleeding risk. So let's start with the science, the lab data that can fuel speculation. And really, this is quite interesting work that looks at obesity and adipokines and really divides the pathways into chronic inflammation and impaired fibrinolysis. And the inflammation is related to inflammatory cytokines and also the increase in certain coagulation factors. And the fibrinolysis impairing is related to the upregulation of PI1 and reducing fibrinolysis. So there is definitely some science behind the relationship. But we have to not talk about obesity. Obesity or high body weight, I'm sure one patient or one of these guys I could talk to about obesity. The other one, I wouldn't like to talk about obesity. I'd say you might be high body weight and you might have a concern. But these guys are different. I think the guy on the left is probably at risk of venous thrombosis just through these various factors. I think of the guy on the right, his only risk of venous thrombosis might be due to the exogenous androgens he's probably using. So how does this recommendation affect patient groups? Well, quite strongly, really. So let's look at some fictional cases. These are the ones, these first two I've described as the unlucky ones. I wouldn't want to be discussing obesity with, say, Alok, who weighed 130 kilograms and is clearly a large guy and a thinker, or perhaps Simon, who weighs in at 155 kilograms. Now, I'm not going to be telling them too much about NOACs or DOACs, except to say that I believe they would be suitable should they develop a thrombosis. And I think they're the unlucky ones, given the ISTH recommendations. I think a couple of other random people, these are the lucky ones. There's Ajay and Alex, and you know, for some reason or another, they will end up with NOACs when they have their VTE, but poor old Simon and Alok will not. And so it's a bit of a lottery, in my view. Now, also a lottery for, say, a 60-year-old woman with a proximal DVT who weighs 93 kilograms. Are we going to give her a DOAC? Well, we might, because she's only 93 kilograms, but actually she's just over 1.5 meters. Are we going to give her a DOAC? Probably, but actually, no, we can't, because her BMI is 40.5. Now, that doesn't make sense to me either. So obesity and high body weight, there's some pathophysiology and pharmacology to consider, as well as the epidemiology. And if we look at people with obesity, with high increased body fat, they have more blood volume, but then so do high body weight people. They have more cardiac output. They have a higher GFR. And the problem comes when we think about using fixed doses. And this is the speculation. If we look at the blue line for the underweight people on the left, the normal weight people in green, and the overweight people in red, that a fixed dose of drug might lead to overdosing in underweight, having the right dose for those in the reference drug range, and too low a dose in those who are overweight. Whereas body weight adjusted might actually lead to overdosing in the overweight. And yet we don't know the evidence for the drug levels and bleeding and drug levels and thrombosis, particularly in individual patients. So a lot of speculation here. What about what's going on at a cellular level? And if we look at fat, we can see that we've got these wonderful adipokines, and some of them on the left are prothrombotic. The ones on the right are antithrombotic, and leptin, pi, resistin, and visfatin are prothrombotic, and they seem to outweigh, if you'll pardon the pun, adiponectin and apelin, and tend to have a prothrombotic state. But we've got some other laboratory stuff too that is of interest. And this work from Piran in 2008 really looked at peak concentrations of DOACs in obese patients over 120 kilograms, somewhat in response to the ISTH. And they looked at patients with Apixaban, dabigatran, and rivaroxaban who'd had at least 3 days of therapy. And when you look at the peak concentrations and the median peak concentrations, they're all very satisfactory in each of these groups. And in fact, none of the patients on Apixaban or rivaroxaban had plasma peak concentrations below the median troughs, which are shown in the dotted lines. So they concluded most patients with a body weight over 120 taking Apixaban, dabigatran, or rivaroxaban for over 3 days had achieved concentrations greater than the median trough level expected from PK studies. So still no change in the guidelines, you know. So let's have a look at the clinical data, and I think this is what really counts. And if we go to the clinical data, the first thing I have to say is that patients tend to behave quite similarly if it's just the characteristics that are changing, not for disease states, but effect modifiers are unlikely to be baseline criteria. They're much likely to be pathological mechanisms associated with different disease states. And here in this lovely meta-analysis from Van Es, we can see that the DOACs are just as good as VKA, but they have a better safety profile. So every reason to give a DOAC. And then what sort of bleeding do they reduce? Well, not just any bleeding, it's bleeding into the brain, dying from bleeding, which tends to run with bleeding into the brain, no increase in GI bleeding in VTE, and an over quarter reduction in the most prominent and common types of bleeding, which lead to hospitalization, which are actually clinically relevant non-major bleeding, usually from our tubes, our gut, our respiratory tract, our nose, or our urothelial tract or urogenital tract. So important changes. And of course, Nick also and our colleagues in Amsterdam looked at body weight. And if we look at this in more detail, we can see that there was clear evidence that if you're under 100 kilograms or over 100 kilograms, and here we have 4,000 patients that were analyzed over 100 kilograms, there was no evidence of a loss of efficacy, no signal whatsoever. And the guideline writers knew this as they're writing the guidelines. In fact, this is the work from the guideline writers, they did their own work. They looked at the efficacy of VK versus DOACs by weight, and this is the VTE studies. I know this is hard to read, but it came direct from the paper. And overall, no difference in efficacy in VTE, and the 1AF study, no difference in efficacy here. So good clinical evidence in the high body weight groups that it works. If we look at by BMI, we can see overall no difference. If we look at Rocket AF, no difference again. Once again, the point estimates tend to favor the DOACs. And if we look at bleeding, we see no differences too. But in this case, we've only got data from rivaroxaban and the edoxaban study. So more recently, some of us have looked at the Apixaban data, and here we've got the extremes of body weight with the AMPLIFY study, which has only been presented in abstract form. But you can look here when patients less than 60 kilograms or more than 120 kilograms, there's no evidence of any heterogeneity, and the point estimates tend to favor Apixaban over Warfarin. Yet for this group, once again, the guidelines say you can't give Apixaban. You've got to give Warfarin and measure the levels if you want to give Apixaban. Then we come to major bleeding in the same study. Once again, no evidence of heterogeneity for the over 120 kilogram group, evidence that favors Apixaban. And if we look at clinically relevant bleeding, now we're getting into a really interesting area where the patients over 120 kilograms, and there's a lot of them. There's almost 300 patients here that was data they could have had. that showed that there was a highly significant reduction in clinically relevant bleeding with a DOAC versus warfarin. They also had some other evidence at their disposal too. They had the AMPLIFY extension study, which we published 7 years ago, and it was very clear that whether you were if you drop half the dose of Apixaban from 5 milligrams twice daily to 2.5, no difference in effectiveness, recurrences or all-cause death, no difference in recurrences, fatal and non-fatal. So no loss of efficacy with reducing the dose by a half, not just a small change in exposure, a halving of the dose. We also published this data for bleeding, and no real problems with bleeding when we dropped the dose from, say, 5 milligrams to 2.5, or compared to placebo, or clinically relevant bleeding. So nothing to indicate a problem with a lower dose or less exposure. Same with rivaroxaban. We published this data 3 years ago. And what you can see is when we drop the dose of rivaroxaban from 20 milligrams to 10 milligrams, no difference in recurrences, no differences in major bleeding or clinically relevant bleeding. So why are they worried about exposure? Well, this is where the speculation began. First of all, a couple of really sort of bland statements. No DOACs have had a dose adjustment for high body weight or obesity. That's true, they don't. No randomized controlled trials of high body weight or obese patients, like you would actually do a study just in obese patients. It beggars belief. And then they said the subgroup analyses of obese patients that were included in the large phase 3 study suggest that DOACs are efficacious and safe in the high body weight patients. And then they said actually in the BMI patients with a BMI over 35, they noted that the major bleeding rate for Apixaban was significantly lower than VKA. And yet still they recommended VKA over DOACs based on speculation. In fact, the speculation was that increasing body weight had a modest effect, not a halving of the dose, but a modest effect on PK, and that the DOACs at the ranges tested, and there might be a slightly reduced, it suggested reduced drug exposure, lower peak concentration, shorter half-lives, possibly. But then they also said checking DOAC-specific anticoagulation blood levels to attempt to assess anticoagulant effects in obese patients is problematic. So it's problematic to do the levels. There might be some changes, and it's problematic to do the levels because of logistic and interpretive reasons. We've got nothing to weigh this against. So having said there might be a modest effect and checking the levels is difficult and problematic, what did they recommend? They recommended, incredibly, they recommended if you're over 40 kilogram, 40 BMI of 40 or 120 kilograms, check the levels. And if they're not in the range, stay on warfarin or go back to warfarin, or, you know, I mean, I don't get it. So here I am with a patient over the last 4 years, a 46-year-old woman. She's 124 kilograms. Her body mass index 42. She's got the usual high creatinine clearance. She's on Enoxaparin. She's been referred for further management. Am I going to give a DOAC to this patient? Am I going to go against the guidelines? Well, I certainly would give a DOAC to this patient. And I think we have to remember once again that guidelines and opinions are different. And if you don't consider all the data, and the important data is the outcomes. Patients don't care about blood tests. They care about, does it work? Is it safer? Is it efficacious? And we have evidence it did. So the guidelines should be balanced, thorough review of the data. In fact, what came later was this work by Bunyawat and colleagues, and it really showed that when you pool all the VTE and the AF data together, you get no difference in outcomes for high body weight and non-high body weight patients. In fact, within the trials, we can see no heterogeneity within any of the trials. These are paired analyses within the forest plot. And they concluded that the clinical outcomes in obese patients are unlikely to differ from those treated with warfarin, that the clinical outcomes are unlikely to differ between obese and non-obese, and that there's no clear evidence about doing levels and clinical outcomes in 2017, but no change in the guidelines. And then just this year, our colleagues down the road at King's College published this paper, which looked at a large number of patients on rivaroxaban, and they looked at fixed dose rivaroxaban in extremes of body weight and did a really elegant pharmacokinetic analysis. And they said rivaroxaban can be used at extremes of body weight, provided the renal function is satisfactory. And they also recommended that the ISTH revises their guidance. They were their exact words. We did a study at Guy's and St Thomas's and with our colleagues at Addenbrooke's in Cambridge with Will Thomas. We looked at 100 patients in the end, but these were the first 95. We looked at 100 patients in the end, over 120, but we looked at these patients originally between 115 and 230 kilograms. They were big patients. They had an average weight of about 140, an average BMI of 45, and very high creatinine clearance. And we wanted to compare. Our hypothesis was to look at the DOAC levels, because that's what the guidance said to do, and compare it to the International Council for Standardization comparators and just see where we are with respect to what would be expected. And we did that knowing that NICE recommended regular monitoring now on the basis of the ISTH guideline, and NICE have still gone for the over 40 BMI and over 120 in body weight. And we looked at this, and we looked at patients with atrial fibrillation and venous thromboembolism. We looked at the peaks and troughs for Apixaban and rivaroxaban, and we found a number of things. We found, first of all, that just about all patients had trough levels within the expected range. I think there were two, and those two were just right on the border where that might be, the lower limit may be 40, they were 38 or 39. So, in 100 patients, we saw just about everyone have normal trough levels, just about everyone have normal peak levels. The peak levels for rivaroxaban were a bit low in some patients, but overall they were within the range that we would expect for therapeutic effect. And also, we also found no linear association between the peak or trough and body weight in this cohort of patients. So the lack of correlation between weight and DOACs and renal function in patients with relatively normal renal function, and that all but two of the trough levels, it should say, were in the expected range. We felt that overall obesity on its own is not sufficient to preclude the use of DOACs and not sufficient to justify measurements and switch to warfarin. So what impact does this have on clinical practice? Well, I think quite a bit. I think it meant that probably over the last 4 years, quite a lot of patients missed out on what would be now considered the best available therapy. I think that also for extended prophylaxis, probably a number of patients would also miss out, because we know that one of the more popular ways of assessing extended prophylaxis, not just here, but mainly in North America and particularly in Canada, is the HER2, the men continue, and that relies on obesity as one of the factors, which is probably one of the most common factors for deciding to continue anticoagulation. And we know that the DOACs can be given most conveniently, and that NICE now recommends DOACs over VKA for continued therapy, particularly Apixaban and rivaroxaban, because of their safety and cost effectiveness, and that you can actually lower the doses quite safely. We also know that we're thinking about how we classify patients for extended prophylaxis much more differently. And we are thinking about not just provoked and unprovoked, but we're thinking about, is it a major factor, a minor factor? Is it persistent? Is it transient? And actually obesity fits into all of this, because most overweight patients with obesity just get called unprovoked, VTE. They're not called provoked by obesity, but occasionally some experts say, well, that obesity is a minor persisting risk factor, and they're at moderate to high risk, and they're the patients you should consider for prolonged anticoagulation, and they'll miss out. So just in the last couple of weeks, there's been an editorial that has been published in response to some of the research, and it was great, and it said, direct oral anticoagulant use in extremes of body weight, time to revisit the guidelines. Well, that's great. Except they came up with their own guideline, which drove me crazy. And they said, now let's just shift it from 120 to 150, and let's just shift it from 40 to a BMI of 40 to 50. Well, more speculation. We don't need that. I mean, we can't treat any patients if we don't extrapolate and interpolate our clinical trials. We have to use common sense. We have to go on clinical factors, not laboratory factors. We're treating patients with recurrences and bleeding, and we need to keep that in mind. Forget the science. The more science you see, the less we know. It's a problem for me. The patient, I got this quote for the day. It actually arrived in my email box today. The patient doesn't care about your science. What he wants to know is, can you cure him? Can we offer them the best drug? And the evidence is that DOACs are the best drugs in this setting, whether you're underweight, and I haven't gone into detail there, overweight or high body weight. So in conclusion, dear colleagues, DOACs for treating VT in patients with obesity and high body weight, the answer, I think, is a resounding yes. And for the guideline writers, I want you to try and think that absence of evidence is not evidence of absence. And we have evidence that high body weight patients do well clinically with DOACs and better than those taking vitamin K antagonists. Please change the guidelines. Thank you very much, Professor Hunt and colleagues.
Thank you very much. That was such a coherent argument. I don't think that anyone has dared to ask you any contradictory questions. Hang on a moment. There's one here. Someone's saying it's brilliant. Here we are. It's from an anonymous attendee. Thank you for your talk. Is there any issue with increased post-thrombotic complications with DOACs and obesity?
Well,
such as
we don't know.
When we have tension.
What we do know is that those two women I showed you the picture of, they are sitting ducks for PTS. And they're sitting ducks for PTS because they're female, they're overweight, and they've got DVT. And they are the classic sort of factors for PTS, and they're at high rate of recurrences. So PTS patients, probably, we're not actually treating the PTS, we're probably actually just stopping recurrences, which might make PTS worse. But for PTS patients, we don't know if DOACs are better than warfarin. What we do know is that if the warfarin's poorly controlled, which it is in a lot of patients, then that's correlated with worse PTS. And we also know that the adherence to DOACs is pretty good compared to vitamin K antagonists and other treatment, because it's more convenient and the side effect profiles are better. So it's an interesting question. I know my colleagues working on the Hokusai VTE study tried to answer that question, but the problem is that there's a lot of missing data and incomplete follow-up. So they're going to get a group that respond rather than not, but it's better than nothing. And we'll see. We'll see if DOACs are as good or not as good or just the same.
Okay, we've got another question from Catherine Hornsby, and just to paraphrase it, I think that she's asking, does the obesity rule apply to patients you're treating with AF? The patients who get DOACs for AF, is it acceptable for obese patients?
Yeah, I mean, we looked at the levels of in AF and VTE patients. We looked at the levels in both. Other people looked at AF patients. I think that we probably need to keep reassuring ourselves. I don't think one study is enough. I'm not saying the work that we and others have done is definitive. What I'm saying is it's good evidence that they seem to work in all patients who require anticoagulation who are obese, and that the levels they achieve when they're obese are as good, if not better, than normal weight patients. I mean, we might have had a compliant group of overweight patients, but you know, most of the levels in the therapeutic range is jolly good. You know, when you're doing routine checking of levels, that's a promising start.
Okay, next question from Catherine Boyd in Northern Ireland, and I'm not sure any of us can answer this. Is BSH planning to publish a guidance for DOACs for overweight patients?
Well, I'm not a hematologist, so I couldn't answer.
So I'm not aware of one. And I was just thinking in my head how we can capitalize on this excellent talk of yours, and perhaps we could send the video of your talk to all the people that have produced the ISTH guidance. Would you object to that?
Look, they're friends of mine, and many of them are friends of mine, and they honestly did what I think was a good job, given a difficult job, given that there was a lot of questions and that sort of thing. So I don't want to be critical. I have been critical of them.
But you have been critical.
Yeah,
but you've done it in a very intellectual way.
Well, I hope what I'm trying to say is that it's easy when you get swept up and you're saying, well, we've got to do something, but actually you might sometimes doing nothing is the best thing, and that's true in clinical practice as well as in guideline writing. So, you know, what I'd be happy for any of them to see it. I'm very fond of all the ones that are on there, but I don't want to. You know, we all have made decisions that we've thought afterwards, well, maybe that wasn't the best decision at the time. Yeah, that's a human error. We're all human.
I think one of the issues about modern thrombosis and hemostasis practice is that there are so many lectures and so many articles that not everybody sees everything. And I think it would be very lovely to send them a copy of this. But
yeah, I'd be happy to. I'd be happy to. Yeah.
More questions.
Even the anonymous patients might like to see themselves on the screen.
Okay. May I ask, please, if the patients are for long-term anticoagulation, will they be needing trough levels every year or not?
No. Look, I think that if something else comes along, you know, with time, they develop renal impairment that's significant, or they are on drugs that they start a new drug that interacts and you think it might lower or raise the levels, then sure. But, you know, let's not go looking for a problem that is not existing. You know, even if the levels were low, we might find they get very good outcomes. I think we're now going to have to look very carefully at the pharmacoepidemiology. We won't have any more randomized controlled trials, despite what guideline writers always ask for. We're going to have to look at the large databases and try and deal with the residual confounding, and you know, try and get answers as accurate as possible. But yeah, we've got more to do. But you know, I think for now we should be confident in using DOACs in high body weight and obese patients.
Okay. So there's a question about low body weight. What should we be doing for those under
So
50
one of the points I wanted to make with high body weight was that they're not all the same. And that's the same with low body weight. So you will have people from, when I go to Asia or lecture in Asia, these are people that literally weigh 40 kilos, and they're well apart from their venous disease or their atrial fibrillation, in the sense that they are actually 40 kilogram patients. Then you have patients with chronic illness that are low body weight, and they're different altogether. And then finally, you have cancer patients or patients with end-stage disease who are cachectic, and they're different too. So we can't just talk about high body weight or low body weight. I agree with Pandy and Eichelboom that, and we've always said this, and that down to 35 kilograms, you don't need to worry. And that's in an adult population. When you get to kids, it's a whole different ballgame. They don't behave like little adults. They have kidneys that can absolutely drop your levels of any drug very quickly. And then we're into 3 times a day dosing and weight-based dosing and age-based dosing. But for adults, down to 35 kilos, I'd treat them the same. And let's face it, when you look at, if you read the literature and look at all the outcomes of the low body weight patients, who has the highest recurrence rates? Not the high body weight, not the normal body weight, it's the low body weight. So don't start fiddling with the doses in low body weight, because they're the ones getting the highest recurrence rates, probably because they're sick, But we need to find out. We need to find out, Beverley. We need to know, is that just being skewed by the sick ones or the ones that might have undiagnosed cancer, or is that actually a feature of low body weight? So I think it's probably the former.
Okay, I need to crack on. Someone's asking, can the slides be shared? But we will have this recording up on the platform within a couple of hours for you to download, and a couple of weeks down the line, you can get it through the Thrombosis UK website forever, until it becomes out of date, which for this talk, probably never. The next comment, the most recent data supports rivaroxaban and apixaban, but what about edoxaban and dabigatran, which have greater proportions of renal clearance? And
well, they're very useful drugs, both of them. And, I mean, I think that we have to be careful about going down the route of 1 or 2 drugs. I think that's a danger. We've got drugs with different different pharmacology and different pharmacokinetics. I find that edoxaban is very useful in patients where I want to drop their dose, but based on low body weight or based on renal function or the use of strong PGPs. I see patients with cancer and other conditions that have strong CYP3A4 interactions, and you're not going to get much trouble with edoxaban because it's got very little CYP3A4. So, and it's a once-a-day drug. It's convenient. I mean, it's I don't want to. I think that the hierarchy is interesting that NICE have chosen. I also know with dabigatran, there are patients that I have some. There's some advantages in managing patients with HIV medications, the protease inhibitors. There's advantages in patients that you want to have the ready availability of a reversing agent like iduricizumab. So, yeah, no, we need to keep a broad church. It would be foolish for us to say, let's put all our eggs into this basket, because the more we've got, the more scope we have to treat patients with the therapy that suits them.
Okay, one last question, and then we need to move on. It's very simple. Can a patient with PE on Apixaban 2.5 BD take rifampicin to treat latent TB, or are they better off on warfarin? Thank you.
Well, I don't have a lot of experience with this, but I understand that, look, if it would be possible to when you have a strong interacting drug like rifampicin, or other medications, some of the drugs we actually use for treating pneumonia, the mycins, for want of a better term, you can measure the levels if you need to. I don't mind measuring levels once or twice, just when there's a change in interacting drugs. I think in the short term, if you haven't got the ability to measure the levels, then warfarin is the right thing to do while they're receiving the antituberculous therapy. But there's a degree of flexibility here depending on the local facilities.
Great, great. Well, that's been a masterpiece. Thank you so much. It was really brilliant.
Pleasure.
Very clear argument, and we need to try and get the guidance changed.
Thank you, Beverley.
Thank you very much. So we're going to move on now. It's really from chalk to cheese, because we're going to talk about a very different subject, but a very important one, and that's mechanical thromboprophylaxis. It's such a pleasure to have Professor Alun Davies here. He is Professor of Vascular Surgery at Imperial and a consultant at Charing Cross and St Mary's Hospital. He really is a world expert in the management of vascular disorders, both arterial and venous. He's been an editor-in-chief of phlebology. He's past president of the European Venous Forum and the Venous Forum at the Royal Society of Medicine. And he's had numerous publications. I think it's over 500 now, and he runs a large research group. So Alun, it's your time. We can't wait to hear about the GAPS trial. Thank you.
Beverley, thank you very much for that introduction. And I'm afraid, listening to Anders talk, I'm sure you're all going to find this rather tedious, but I'll try and make it as interesting and as exciting as I can. As no doubt most of you will be well and truly aware that any patient who's coming into hospital has an increased risk of developing a VTE. And certainly in the United Kingdom, we're now looking at VTE rates after 90 days of hospitalization, and hospitals are often assessed with respect to their performance and look to see what the rates potentially are. And we all know that there are significant health burdens and societal costs. Now, in the United Kingdom, in about 2005, it was sort of highlighted by an all-parliamentary group that there were issues with respect to VTE prevention. This subsequently led to NICE guidelines, and there were various exemplar centres in the UK that were set up. The Department of Health, to try and reinforce this, developed the use of sequins so that patients and hospitals were rewarded if their patients were, in the UK, just assessed to have appropriate prophylaxis, i.e. a risk assessment score was used, but we never quite got to the stage where we actually assessed as to whether they were receiving appropriate prophylaxis. This is not only a UK phenomena. If you look at the United States, there are various examples where hospital groups are rewarded if their patients are getting appropriate prophylaxis regimens. So not only is it important from the patient perspective, but it's also important for the hospital. In the United Kingdom, you'll be very familiar with one of the risk assessment tools, which is that of the Department of Health. And I've highlighted another one, which is the Caprini score, which is often used in surgical patients, because I will talk about this a little bit later on. But basically, the overall tenet is that you're looking at risk assessing patients for their thrombotic risk, but also seeing if they have got a potential bleeding risk and what you should do with appropriate prophylaxis. Now, this just highlights very simply that you can either use drugs and mechanical or mobility as varying types of prophylaxis. So I want to highlight to you a particular example of that of using graduated compression stockings, otherwise known as thromboembolic deterrent stockings. And the key thing is that in the NICE recommendations in April 2017, it was made very clear that for all inpatients having surgery, that patients should be offered thigh-length graduated compression stockings, and then they may additionally required to have pharmacological prophylaxis as well. There were then various iterations, and we've seen that in 2000 and 2018, there were revisions of the NICE guidance, but very much emphasizing the importance of mechanical prophylaxis. Now, when you look at all the various changes in guidelines, these are some of the key changes that occurred in the 2018 guidelines. And this is a slide I sort of purloined from one of your colleagues, Dr. Shapiro, who works in Oxford. but very much wanted to highlight the key changes and comments with respect to mechanical thromboprophylaxis. And then there was this study that was published that actually suggested that there would be no difference for mechanical thromboprophylaxis for surgical patients. Now, going on to look at graduated compression stockings, there was a review by the Cochrane Library, which gave us some evidence. Many of you will be familiar with the CLOT1 study that was published, very much showing that graduated compression stockings were actually of no benefit and maybe of damaging effect or deleterious effect for those patients who were acutely admitted with stroke. There were various surgical papers that came out suggesting and raising questions, and then we conducted a summation analysis to actually look if there were any benefit in those patients who were deemed to be high or medium surgical risk, and again really highlighted that really the evidence was not very good if the patients were having low molecular weight heparin as well, i.e. was there any adjuvant benefit. We then had to do an estimation of what we thought in the high and medium risk patients the VTE rate was, and if you looked at all the data, we came out with a figure of just under 6%. Now we know that the graduated compression stockings in the UK, it's a rough estimate, but roughly £63 million per year is spent on compression hosiery to deter surgical patients and developing a VTE. We know that they're not mainly always particularly comfortable, and there can often be poor compliance on the wards. An audit done in our own institution 4 or 5 years ago showed that the compliance with graduated compression stockings was 11%. So I'd now like to highlight to you a study that we ran and was funded by the NIHR, and you can see that Beverley was a co-applicant on that study, and there was a range of individuals from varying backgrounds who formed part of the applicant group. This was a very simple study. It was a one-to-one study with molecular weight heparin alone as one intervention and low molecular weight heparin and compression hosiery. And there you can see the sample size calculation. The fall protocol was published in the European Journal of Surgery in 2017 and is available there for you all to read. But the key inclusion criteria were they were elective surgical inpatients who were deemed to be at moderate or high surgical risk as per the Department of Health guidelines. There were some obvious exclusions, those who had a contraindication to either low molecular weight heparin or graduated compression, those who had a known thrombophilia, those who were on the time of admission were having anticoagulation therapy, a previous VTE, the use of intermittent pneumatic compression after the immediate surgery or recovery, the use of an IVC filter, but probably key in this was those who also required extended thromboprophylaxis, i.e. having major pelvic, abdominal, or lower limb arthroplasty. So the primary endpoint was a combination endpoint of asymptomatic and symptomatic lower limb deep vein thrombosis or symptomatic pulmonary emboli within 90 days of surgery. Now the asymptomatic group were such that all patients were required to have a duplex scan at around about 3 weeks to rule out a DVT. Then there were the classic secondary endpoints such as quality of life, complication rate, compliance, etc. Statistical analysis was performed in a standard fashion. And we had 7 trial centres dotted around the UK. And to all these people, I'm very grateful for having recruited patients to this study. Now, this study was slightly complicated in that initially we found that taking all comers, we had a significantly lower than anticipated rate. And we were actually, with the DMC, going to look at any particular outcomes that would suggest that we should stop the study. But we didn't actually get up to a significantly big enough event rate for our interim analysis. So the decision was taken that we would then stop recruiting medium risk patients and we would only recruit patients who are over 65 and were deemed to be in a high-risk group. So for completeness, we screened just under 12,000 patients. We randomized 1,905 patients, and you can see that they were equally randomized between the two groups, and that overall our follow-up was very good, and a significantly good number were included in the subsequent analysis. So to summarize, we recruited 16% of the patients screened, and however, we had an exceedingly good follow-up of 98%. So if we were to look at our baseline characteristics, you can see very importantly, and I have actually given you the data from the US using the UK system and the Caprini scoring system. But in the UK, the majority of our patients had 84% of them would have been deemed to be of high risk, and just under 70% using the Caprini score, because that has a slightly different scoring system, were deemed to be at the highest risk. So you would have expected these patients to be having VTE events. There were some reasons that people fell out because they did not receive surgery because of times of recruitment and the fact that there was a change in the plan, or patients decided not to have surgery, but this was equally balanced between both arms. If we look at the treatment received, there was some crossover, and there was some issue with respect to patients not receiving their prescribed treatment, be that stockings or pharmacological medication. And at one point, we did have to contact the medical directors of the various trusts involved just to highlight that patients weren't actually receiving the prophylaxis that would actually have been advised. Again, the reasons for them not receiving low molecular weight heparin are highlighted there quite clearly, and these usually were issues around about prescription or patients being discharged from the hospital too early. So what are our results? This was a non-inferiority study, and I've given you again the data as a per protocol analysis and as an intention to treat, and also highlighted the results with respect to the Caprini score and the highest risk groups. But as you can see, in no group was there any evidence to suggest that we were not at meeting a non-inferiority margin of 3.5%. So the overall summary was that graduated compression stockings alone were non-inferior compared to, sorry, I got that wrong. It was low molecular weight heparin alone was not inferior to combined graduated compression stockings and low molecular weight heparin. And the overall data, you can see here that the VTE result rate was less than 1.6% if you look at both groups. And again, you can see very clearly that there was no benefit with respect to graduated compression stockings as an adjuvant to the low molecular weight heparin. Again, this really to highlight the subpopulations, to highlight to you that we are talking about patients who are undoubtedly at high risk. And similarly, again, with the Caprini score, again, very clearly, there was no difference with respect to the outcome. If we then look at with respect to compliance, it's very important for us to note that we were talking about a compliance stroke adherence rate with stockings and low molecular weight heparin of over 80%. If we look at the adverse events, you can see that actually for low molecular weight heparin and graduated compression stockings, it came up at just around 6.5%. But I think it does have to be acknowledged this was mainly because people actually did not like wearing their stockings and they were getting discomfort. We published this recently in the British Medical Journal, and it was very clear, and to summarize, that there really is no adjuvant benefit from using graduated compression stockings in this cohort of patients who are receiving low molecular weight heparin. But there are some cohorts that need some further consideration, and I will comment to you a little bit more about those. So what are the conclusions? Well, it's important that there are some limitations, but as you know, we were using an asymptomatic diagnosis of using duplex, and 13% of patients did not get their duplex at the stipulated time, but this was equally distributed across both arms. And also the study did not include anybody who required extended prophylaxis post-discharge. So the conclusions are very clearly, this is the first large randomized controlled trial to show that there is no adjuvant benefit to low molecular weight heparin, and this is based on a non-inferiority trial. So the implications for this are that we probably need to think about some urgent revision of guidelines, and that there are further studies that need to be conducted. Now, I think what is very important is that you don't go out and say that graduated compression stockings, potentially in the emergency patient or in the low-risk surgical patient, are of no value. But if you look at the extended prophylaxis group, we've done a recent summation analysis and have actually shown that there really is no good evidence to support graduated compression stockings in those patients who are having extended pharmacological prophylaxis. And if you take the low-risk surgical group, i.e. those who are not having low molecular weight heparin, but are just having graduated compression stockings, the evidence base for those is inordinately weak as well. So we would like to suggest, and we have put various bids and things to the NIHR, but this is where our thoughts are from the GAPS group with respect to 3 further trials. Is there any adjuvant benefit in the emergency surgical patient? Undoubtedly, in the prolonged patient group that I highlighted to you, who are either the arthroplasty group or the pelvic and abdominal surgery group, they need to have graduated compression stockings? And certainly in the low-risk surgical day case patient, or the patient who's in for one night only, is there actually any benefit of graduated compression stockings at all? So now I'd like to just leave the comments with respect to gaps, but I am going to show you my final slide, which I'd like you all to look at very clearly and then very kindly answer some questions, because it would help us with our future research. But now I'd like to talk to you about neuromuscular stimulation, which I know wasn't part of my brief, but it's there to be included with pneumatic compression. Now, the reason I've included both together, because they both work on the mechanism of apps, including increased return of blood to the heart, including improving venous blood flow, i.e. by doing that, reducing your risk of developing a VTE or DVT. If we look at the data for intermittent pneumatic compression, this was an analysis was done about 2 or 3 years ago, and I apologize for the very busy slide, but you can see I've highlighted it for DVT and PE. You can see very clearly that there is evidence from the forest plot suggesting that there's undoubtedly a benefit from pneumatic compression compared to the use of no pneumatic compression alone. Certainly, if you look at the literature, again, there's evidence of its benefit with respect to surgery. And just to highlight another study, the CLOT3 study, where patients had pneumatic compression who had a stroke. Again, there was a benefit in reducing their risk of DVT, but also there was an overall survival benefit in that group as opposed to those that did not receive pneumatic compression. If we look at intermittent pneumatic compression and look at the Cochrane review, this is basically a summary of that study. If you take intermittent pneumatic compression alone and compare it with intermittent pneumatic compression and chemoprophylaxis, you can see that the adjuvant of the 2 treatments, there is a significant reduction in the number of patients having a PE or a DVT. If you look at those patients who are either having pharmacological manipulation or pharmacological manipulation and adjuvant pneumatic compression, you can see, again, you see the same phenomena in both PE and DVT, that there is a risk reduction in using a combination. So maybe we should be offering combination to all patients. However, many of you will have read this study that came out from the Middle East, very nicely highlighting that actually there was no benefit in those patients in ITU from having the adjuvant benefit of pneumatic compression and chemoprophylaxis. So I would suggest to you the jury is potentially out. If I then want to just whet your appetite a little bit about neuromuscular stimulation, which probably does actually increase the blood flow out of the calf more than intermittent pneumatic compression. And this is a study that very clearly highlights that just looking at blood flow parameters, and therefore suggests that it may be of a greater benefit than neuromuscular stimulation. We've conducted a review about 2 years ago now looking at the benefits of neuromuscular stimulation and the prevention of VTE. I would completely accept there are very few studies. It ranges from 3 to 5. But if you look at neuromuscular stimulation alone versus nothing else, it does undoubtedly reduce the incidence of VTE in hospital. If you look at neuromuscular stimulation, again, only 3 series, and you can say very old studies with comparing heparin, you can see that there is a benefit overall for chemoprophylaxis. If you then look at the studies that are available and you look at the benefit of neuromuscular stimulation plus heparin, both together are undoubtedly better than heparin alone. So it is an area that does undoubtedly need further evaluation. But to summarize, we've shown, the Cochrane review has shown quite clearly that there are benefits of using neuromuscular stimulation. And NICE has supported it with a statement to suggest that in those patients who are unable to tolerate other mechanical devices or pharmacological, then you should think about using neuromuscular stimulation. And this particularly applies to the neurosurgical group. So I would like to suggest to you, I've probably left you with a few questions to which I don't know the answer, but maybe Anders and Beverley will. But I would just like to highlight in the generality, I think we need to be able to highlight better those patients who are at risk of developing a VTE. We need to talk a little bit about those who are put into scenarios where they are at a greater risk, such as flight, and what we think about the immobile patient in the nursing home. Which are the most appropriate modes of VTE prophylaxis, and how should we actually go and individualize this? And I very much stayed away from talking about COVID, but how does COVID influence any of those future aspirations that I've talked about? So I'm going to leave you with my final slide, which I'd like to leave there just for a little bit of time while people are asking questions, because it would be great if anybody would be prepared to answer this survey. It'll only take about 2 minutes, but it will help us better inform us and PPI for our future potentially gap studies. Thank you all very much.
Fantastic, Alan, because you've summarized a load of data really quickly. Thank you very much. I must say that the survey is very quick. I've done it myself, and it literally does take a minute. So I think it's really helpful. So Alan, can you say a little bit more before we look at some of the questions about the implications of gaps? Because if you were writing guidance now for mechanical thromboprophylaxis in 2020, what would you be recommending in the surgical and the medical patients?
I think it's very difficult. I can't really make any comment on the medical patients at all, because that obviously wasn't the trial cohort. But I think it would be really very clear for those patients who are high in surgical risk, who are undergoing a general surgical, ENT, or even orthopedic surgery, who are not deemed to require extended prophylaxis. There really is no argument for giving them graduated compression stockings. And we are now obviously in an implementation phase where are doing further surveys to look to see what are the barriers to implementation. And obviously the publication of the trial got wrapped up with respect to COVID. I think most hematological committees in most trusts spent most of their time talking about COVID, but it's now very much about getting the message out there and getting NICE to pick it up and see if it's prepared to adopt it as a recommendation. But I think the other key thing that needs to come out from it is actually how low the incidence of symptomatic VTE is. And actually, the vast majority of our VTEs were asymptomatic. And this may be very much a surgical thought that actually a very high number of patients, be they surgical or hospitalized patients, get a VTE. The body deals with it and it never becomes a subsequent problem. But I accept that's a complete posture. That is where I sit probably.
No, I think there's this background of massive improvement in surgical care and faster turnaround time of the patients, faster anesthetics. Then we know about the need to keep them hydrated and well oxygenated and to get them moving as soon as they're back in the ward. And there's a beautiful summary paper showing that just the rates of VTE has dropped dramatically in surgical patients over the last 50 years. And so, I mean, we are doing very well with low molecular weight heparins, and we seem to have reached a pinnacle. I don't think we can go any further. We can't give them more, they bleed more. We need a new agent to take things on even further. But coming back to stockings, so the absence of evidence, the absence of guidelines, nice guidelines about what to do with mechanical thromboprophylaxis is very similar to how we were with the high rates of thrombosis in the COVID patients in March and April. Nobody had any guidelines at all, and everybody started to do something different in the hospitals. I'm talking to NICE tomorrow, and I think that that's a message I need to remind them. They need to produce some guidance, otherwise we will all be doing very different things. In your short survey, you ask about the hospital and what are we doing in the hospital about applying the GAP study, and we're all doing something, but I'm not sure we're all doing the same thing. What are you doing in your hospitals with the GAPS data?
We're in the process. It's just gone to our hematology committee, and I should say our thrombosis committee, on which
the thrombosis and thromboprophylaxis committee present in every NHS England hospital. So
the straightforward answer is it's in the process of going through, and we're talking about adopting it. But I was being quite straight, Beverley. We have been overwhelmed and with respect to discussion about COVID. So we're just trying to work out the right time to make the push. But it is sitting there because the chair of our committee was one of the applicants. So we are very keen to get it implemented. And as you know, there are some trusts who were using it as a policy, and it has reinforced what was already being done in certain trusts. But I think the key thing is actually to get NICE to alter its recommendation that blanketly that all surgical patients need to have stockings.
Yeah. Okay. I'm just going to go through some of the questions now. So, here's a real horror. A very good question. Thank you, Chiara. Any consideration for a similar trial in maternity? ARCOG says one thing, NICE another.
The answer,
no evidence.
The straightforward answer with obstetrics. When we were setting up the GAPS trial, we did with a few obstetrician colleagues and undenied about including obstetrics, but decided that it was actually going to be too difficult with people not really having equipoise in various different units. My own view is that I think it is undoubtedly an area where you could actually rerun the GAPS trial.
So, you know, the only evidence at all in maternity is one study looking at flow in the iliac vein in patients wearing stockings or not wearing stockings in maternity. And I think it looked at 5 patients and it was Ian Greer, that's it. And so they really are extrapolating what they're doing from surgery. So
And I think the other thing that's important, and if there are any obstetricians listening, they'll know that there's a lot of debate now as to the position, as to whether a lady should be on her back or on her side at the time of delivery. And potentially that in itself may well alter flow patterns and other things. Now, it's all being looked at much more in what for comfort and whether you can increase the rate of vaginal delivery by actually having somebody on their side during the second and third phase of labor. But it is something that is quite interesting, and I come across that wearing one of my other hats.
Great, and there's a message here from Brogan 1930. Did you use TED stockings or grade 2 European class compression stockings in your study?
We use graduated compression thromboembolic deterrent stockings.
Okay. So Sue Bacon, nice to see she's on the line. Oh, hang on a moment, you've just moved it up, it's just disappeared. We have suggested using the GECO for patients at high risk of bleeding and thrombosis, e.g. prostatectomy, as we've had a couple of deaths. So, I mean, the information about the GECO is limited, whereas there are huge numbers of studies of IPC, and there's no comparison of GECO and IPC. Which would you prefer, Alan?
Right, I think I'm very clear about neuromuscular stimulation, and particularly the GECO device, is that it only works in around about 80 to 90% of patients when you try and attach it. And one of the issues with it is that you can get some pressure heel movement, and there's the potential to develop a pressure sore. I would agree with you. I think at the moment, all the evidence and all the good evidence there is for the use of pneumatic compression. It's much easier to use. Everybody is familiar to using it, and give or take, you can use it on every patient. Whereas with the GECO device, you can't always get it to stimulate the nerve. You do have some adhesive problems with it. So I think it's a very good alternative if you can't use anything else, but I certainly wouldn't put it there as being the first line, and I think that is how the NICE recommendation sits.
Yeah, and Sue's also pointed out it's very expensive, £23 a day. So I'm not sure that IPC isn't hitting that sort of number. Okay, another question from Elfatheria Porvalaki. Do you think we need more data indicating the need of multimodal thromboprophylaxis, and for which patients?
Well, I think the answer is yes and no. And you'll think this is a slightly mad statement. If you look at the most present NICE guidance, I think there are very few clinicians who can actually remember exactly the intricacies of what you should do for each of the different surgical disciplines. And I'm going to put my hand up and say, I have to look it up if you're going to ask me what the latest thing is on spinal surgery, because it may, or this bit of spinal surgery. I think so the answer is the more people you can cover with a blanket, can see how it's simpler for everybody to use. But I accept the other argument of how important personalized medicine is and where you actually get that balance. And the thing I would suggest that we're probably not very good at, or shall I say surgeons aren't very good at, because my two eminent medical colleagues who are looking at me down the screen, is that we're not very good at assessing people before they come into an environment. So why can't we actually do most of these RAT assessments, whatever we decide is the appropriate RAT assessment, a long time before the patient comes into hospital? You've got all their history, you've got everything, rather than something you rush to do as they are on a ward. You'll see from the GAPS trial, you can see that even though things were prescribed, there was up to 20% of people did not get their prescription of what they needed to have. And this is, even though you're doing this within a trial, and we were being pragmatic, and I think you would still be quite surprised to actually do a surprise audit, even though we have electronic data now, to being actually how good we are, except we're much better at doing the assessments, but how good we are at ensuring that our patients are getting the appropriate treatments. And I think that really takes me on to another hobby horse, that if we were doing the assessments earlier and engaging more with the patients themselves would probably actually push to get their appropriate prophylaxis and would be more aware. So I know that's probably given not a very clean answer to the question, but I can see that there is a lot to be said for having it personalized, but we want to make sure that even if it's personalized, it is actually deliverable to the patients in a large factory environment.
Okay, there's several people asking about which anti-embolic stockings were used in the GAPS study.
The straightforward answer, it depended on 7 sites as to what their procurement had, and so there was no, we weren't looking at any particular manufacturer. People were allowed to use above knee or below knee, because if you look at all the evidence, there really is no good evidence to support an argument for one or t'other. So that was allowed, each institution was allowed to be pragmatic.
Okay, and of course, one of the issues with anti-embolic stockings is different companies produce different sizes. And I mean, some of the companies have up to 40 different sizes. You always wonder if the patients get the right size.
Well,
and others have such a small range of sizes, you worry that they're not working.
Well, I think the answer is that what tends to happen is that some people get measured, some people get their leg looked at, and it's small, medium, large, and they're short, average, or tall, and that is roughly what happens. And you'll often, when you're going into a room or to a bed space, you'll often see that the TED stocking is already sitting there with the towel, the gown, and really no real measurement has actually happened at all. And we've all seen patients who stockings are badly fitted. But I'll tell you a little story which will make up for my lack of sense of humor. It was the time when I was the sequin lead for VTE prophylaxis in the trust, and I was operating in theatre, and I was asked to come to recovery to see a neurosurgical patient who had some TED stockings on. This patient had TED stockings on, but whatever the nurse told the patient to do, this patient had bilateral lower limb prostheses on, so these TED stockings had been put on over their artificial limbs. And if it hadn't been for a governance reason, I would have taken a photo, because the whole of recovery, as you can imagine, were in stitches. So it just shows you what can happen with dogma.
Good.
Oh dear. And do you want to make any comments?
What on stocking?
Yes.
Well, I'm still yet to see any evidence that stockings work, and I think that, you know, Alan did this wonderful study of GAPS with 1,900 patients. We did 795 patients between 2002 and 2004. Very similar design, fondaparinux with stockings or fondaparinux on its own. We showed no difference. So I think the answer is, you know, give pharmacological prophylaxis in general, unless you can't, and then you better do something better than stockings. So, I mean, I've worked in thromboprophylaxis for 30 years, and I'm very interested in it. I don't see any evidence in medical patients. I think that the more sophisticated types of mechanical prophylaxis may have a role, but we need, from a epidemiological and methodological point of view, we need decent outcomes. We know that in surgical patients, pharmacological prophylaxis reduces mortality from PE by 2/3, and we know that it reduces total mortality by about 20%, which is 2/3 of 30%, because 30% of surgical patients die of PE. In medical patients, only 10% die of PE. So even if you reduce it by a half, you still only get a 5% overall reduction in the mortality rate. So you need much bigger studies in medicine. And my view is that in medicine, you know, once again, we need to be thinking pharmacologically. One other comment, the 2007 NICE guidelines, which put stockings front and center, I mean, that was a sort of research bias from the person in charge, Professor Treasure, at the time. I remember arguing with him saying, we got all this evidence that pharmacological prophylaxis reduces PE mortality and total mortality. You've got no evidence for stockings. I said, you know, what are you doing? He said, well, this is a political process, Ander. I remember the comments. And you know, for me, you kind of need to go back to George W. Bush and have the dead or alive outcome. You need, you know, if you've got an unblinded intervention, which stockings are, even the assessment of PE is going to be slightly biased by the presence of stockings or not. So I think we need to see some changes, at least in PE mortality, not just PE. And we haven't seen PE changes with stockings. We have with IPS and, or IPC, I should say. So I think that the work that Alun's doing is vital and really helping us define who are the best patients for thromboprophylaxis and what are the best treatments. And at the moment, they're pharmacological and more complex mechanical.
Right. I think that is the perfect place to end. I think it's been absolutely marvelous. We've had two of you with your whopping brains telling us all your most recent thoughts and your lovely research. I think this has just been great. I particularly love it because we've hardly mentioned COVID and we're really moving forward in these areas. I particularly want to say thank you to Jo Jerome, who's sitting here, and I failed to introduce her at the start. She's our Chief Executive Officer of Thrombosis UK, and she's organised all of these meetings. So Jo, another triumph. So just to confirm to everybody listening, if you want a copy of the recording, it will be available in a few hours' time on our platform, and then it will be on our website forever until something else comes along, which I don't think will ever be as good again. We have to say thank you to all our sponsors and supporters, and I need to remind you all to visit the virtual exhibition area, and there's stands from professional bodies, and you can actually chat to them and get quite a lot of information. So thank you so much for coming. Thank you very much to the speakers. Have a great day, enjoy your evening, and stay safe.